Peters. I'm the medical director of German clinic and Campus Clinic here. We opened German clinic in 2018, just around the corner here, up Calle Calvario, which is next to the Hotel Bavaria. We opened Campus Clinic, or took over Campus Clinic last year from actually a Dutch group, by the way. And we transformed that a little bit into the same kind of clinic as the German clinic, which is a clinic dedicated to private international patients who are asking for a dedicated service and time, which is what we offer, apart from our expertise as doctors. And that's what we're trying to show to people as well during this little event, Ask the Expert, which means that we invite one of our experts to talk about his or her specialty once a month, right? Joris is kind to repeat his talk from some time ago, where he speaks about his specialty, the hip surgery, and especially the interior approach, which I think is something new. And Joris, I probably don't have to introduce him to you, as he's a very renowned Dutch surgeon who is now a trainer for this interior approach in hips here in southern Spain, and passing on his experience to Spanish doctors here who would like to learn this procedure. It makes a huge difference, but that's something Joris will be able to tell you about. And we're very glad to have him here, and I'm going to pass over the word to him. So, are you welcome?
Okay. Thanks for the introduction, Michael. I'm a hip, knee and elbow surgeon.
Thank you.
And come a little bit closer. It's a small group. Maybe Peter and Andrea can come a little bit to the front seats. Now let's do an interactive session with an orthopedic surgeon since 2010.
That's much better.
Trained in the Netherlands. Thanks for the introduction.
I did there
Michael.
my PhD as
I'm
well.
hip, elbow, knee and elbow surgeon. I was a trainer
started
in a big hospital in Hague with 20 surgeons, some residents, and I was head of the training program. And in 2020, I'm an orthopedic surgeon since 2010, trained in the Netherlands.
Young kids.
I did there my PhD as well, about elbow prosthesis. I was a trainer in
How to solve hip problems.
20 surgeons, some
The hip,
residents.
where's the hip?
And I was head of the training program.
Where's the hip?
And in 2022 we moved. And where's the hip joint?
Somewhere in there.
In the groin, here, in the groin. The hip is in the groin. So if patients have hip problems, I have pain in my hip, they always point this side, but it's in the groin. Now where to start if you have hip problems? There are different diagnoses, some red flags, and some short evaluation of the different therapies. Now it's important to know the age of the patient. There's a difference if you're 22 or 62 or 82. Then it's acute or chronic onset. If it's acute as a trauma, chronic it's more degenerative. Is there a hip spine problem? If you have some herniation or you have some stenosis or degeneration in your lower back, can evoke hip problems. And also knee pain can be caused by hip problems. And always ask for hip dysplasia in childhood, osteoporosis, use of prednisone, alcoholism, drugs, all that things. Now, if a patient comes to my consultation, the first thing is to look at the walking pattern. There's a difference if you walk like normal or like limping, like this. And I see a lot of limping patients. That's due to pain, but can also be due to muscle imbalance. It can be caused by referred pain in the knee, and it's important to see the alignment of the leg. Is it a straight leg, or is it a varus like this, or valgus, this? And Trendelenburg. What's a Trendelenburg? Rick, what's a Trendelenburg? You know Trendelenburg? Trendelenburg? There's one Trendelenburg. Is to ask the patient to stand on one leg, and if you can hold it, you have a good abductor muscle, but if you can hold it, it goes like this. So you get this pattern when you walk. the passive and active range of motion to differentiate between muscle problems or joint problems. If you don't have pain with passive motions, there's no hip problem, no joint problem. But if you have pain with passive and active motion, yeah, then there's a muscle problem. Sensibility of the skin, the vascular pulsations, so are your vessels normal? There are no stenosis or other problems. And last second Bracard is to exclude neurological problems, like if you lift your leg, you can impinge, like here. Does it work? Oh, here. It's like here. If you stretch your nerve here, and you get some pain in your leg, you can have some stretching of your nerve due to a slip disc. And always compare it with the other side. So with the left and the right side, always compare it. Some people are very flexible, and the movement looks like it's normal. But if you compare it with the other side, it's less than the normal situation. Above 40s, it's better to start with the X-ray. There can be some process of degeneration, and we use the Kelvin-Lorentz classification. So grade 0 is normal, no osteoarthritis, and grade 4 is bone on bone, and that's the same for hips and knees. So if you are in grade 3 or 4, you have to think about replacement surgery, and in grade 1 or 2, you can think about physiotherapy, injections. Now, MRI scans are very popular in Spain. There are a lot of people from with the age of 80, they come with an MRI scan with some signs of osteoarthritis. So you can better start with a normal X-ray instead of an MRI scan. But the MRI scan is meant for soft tissue problems, liquids, cysts, osteonecrosis, tumors. So more the soft tissue problems. And if you have any doubt about the spine, you can make an MRI scan of the lumbar spine to exclude the herniations, stenosis, tumors.
What is stenosis?
It's less space for the nerves.
No. In the spine.
In the spine. You can also have vascular stenosis, less space for your blood. In the CT scan, it's meant for bone tumors, bony defects, and the pre-op planning. Now, this is an X-ray of a pelvis. And Alice, what's the problem here? This is a hip joint, and this is acetabulum. And there's less coverage of the femoral head. So normally, if you have a you have the femoral head, and there you have the coverage of the acetabulum. But if it's like this, there's not a good coverage of the femoral head. So you get a higher pressure, and you will get osteoarthritis in the future. So as you can see here.
That's dysplasia, no?
Mm-hmm. Dysplasia. With osteoarthritis. Osteoarthritis is the same as arthrosis in other languages. And here is a lot more pressure here, and you see narrowing of the joint space. This is not a problem. If patients say, okay, I have pain on the lateral side, only here, it can be a bursitis, like this. It can also be a tendinitis. That doesn't work. Here, some irritation of the connection between the tendon and the bone. It's difficult to differentiate between both diagnoses. Now, what's the treatment? There are a lot of treatments: infiltration, stretching of this ligament on the lateral side, infiltration with cortisone, with plasma, with hyaluronic acid. There are immunotherapy. There are a lot of different therapies, but none of the therapies has been proven for the long term. And PRP, PR plasma. But it's not proven for the long term. And you can do surgery to clean it, but it's the same. In fact, we stopped with it in the Netherlands, but in the past we did it for a few years. But yeah, the long-term effects are very poor.
Stem cell infusion.
Yeah, it's the same. It's not proven at the long term.
Yeah.
So it helps maybe 1 or 2 years and then comes back. But stretching is of importance. Stretching of the ligament. This can give some tendinitis of the iliopsoas muscle. It's a muscle. It starts in your lower back and goes to your groin. It's the elevator of your leg. So if you lift your leg, you can feel the tendon there. It's a difficult diagnosis. It's more in your groin, and it looks like it's osteoarthritis. But you can do it. The exercise, the examination, you can do it passively and actively. And with these two tests, you can differentiate it. It's active leg lifting. That's painful, and you can make an MRI scan to prove it. And if it's not very clear, you can do an ultra-guidance infiltration with cortisone, and it helps for a few months, but it's to get a diagnosis. And it's very popular in Spain to put a piriformis syndrome diagnosis on patients. Yeah, it's you see it in a lot of running people. If you get more swelling of your muscles here, on the posterior part of your hip, you can compress your big nerve that goes to your lower leg, the sciatic nerve, and that's one of the most popular diagnoses here when you have pain in your butt. You can use this diagnosis if you have excluded all the other diagnoses. It's the rest diagnosis. And treatments, plasma, acids, immunotherapy, a lot of different therapies and stretching. The labral tears, some rupture here. It's a part of your acetabulum. There's some small line of cartilage that gives some extra depth to your acetabulum. And some young athletes make some spagats, and they can rupture that labrum. But it's only painful with passive examination. So passive movements, deep flexion, and hyperabduction or hyperadduction can cause this pain. And with a good MRI scan, high resolution scan, you can exclude and prove this problem. And then the cam and pincer impingement. The pincer is it's some difference in the anatomy of the acetabulum. There's some extra lip here, and that can cause some impingement, and can hurt your labrum as well. That's an anatomical problem. You can often see it in women. And the cam impingement is some extra bone formation here, and you can also get some impingement problems. And then the combined form. So that the pincer is in young middle-aged females, and the cam is in male athletes. And they think if you are a very active young sporter in your childhood, you train 10 times a week, you can have some overuse of your growth plate here. There's some growth plate, this line, and you get some shifting. And with that shifting, you get an extra bump here, and that's the reason some orthopedic surgeons say don't sport too much in your childhood. Arthroscopy of the hip. It's popular in Spain. I see a lot of patients above 60 with after hip arthroscopies, and they clean the hip, and it's well paid in Spain if you have a private insurance. You can use it to change the anatomy of your femoral head. So remove the cam or the pincer impingement, to remove loose bodies and repair tears Um, but there are some new protocols started in Holland and in England, and they say, okay, don't do it above 45 years. Don't do it if you have any dysplasia of the hip or some signs of osteoarthritis, or you are too overweighted. So they limited the indications for this kind of surgery. And on my specialty, osteoarthritis of the hip. What kind of pain do you have, Peter, with this problem?
I'd say pain in your groin,
Pain in your groin? Yeah.
on that side,
Mm-hmm.
especially after a walking exercise.
And what?
Usually walking distance becomes very limited.
Yeah, and very important, pain at night. Pain at night, it's for us one of the best indications to switch to surgery. A pain at night, and you can solve it with any painkiller. Yeah, that's the reason to surgery. And then you have the standard osteoarthritis, arthrosis. And you have the osteonecrosis, that's some damaging of the vessel here, the blood supply. And you get a change of the femoral head configuration, and that means that if it's not like a ball, it doesn't fit anymore, and then you get the osteoarthritis. Now, I started in 2008 with hip replacement by the direct anterior approach. That was a new approach in Holland. Formerly it was developed in France, but it came to Holland without any additional treatment with traction tables. So we changed it. It was in the region The Hague in Holland, and it's different from the old method. The old method, you have to cut the muscle here or on the lateral side and to fix it again after the surgery. But this method, you use the green line and you use the natural interval between both muscles here. So you don't have to cut the muscles and you don't have to repair them afterwards. And you can do it with a short stem prosthesis. So this short stem and the cup. And then I did it for more than 2,000 surgeries. And in Holland, when we started, it was 4% of the patients were operated by this method. And nowadays it's more than 45%. But in Spain it's still, I think 2-3%. So that was the reason that Stryker, that's the company of this prosthesis, asked me to become a consultant here in Spain to help other surgeons to learn this method.
And why is that?
It's a good question. It's because of the learning curve. It takes you, I think, 80 up to 100 surgeries to get familiar with it.
It's like keyhole surgery.
Keyhole surgery, and in the beginning you have a lot of problems with getting the entrance to the femur and to reduce your blood loss, and that's so it takes you a lot of surgeries to
now,
look at it.
why does it take so long for Spain now to recognize this? If they've done it in Holland.
Now in Holland,
they do a lot of surgery. Like, why don't they follow? Or
now they are afraid of this surgery because in the beginning there were a lot of fractures and hematomas and other problems, and you have to do it with a few surgeons together, and you need a good instructor who learns you the tips and the tricks, and that's the problem. And there are some people are afraid of this surgery to introduce it in their hospital because they're afraid of their practice.
Start a problem.
Yeah, they start a problem and for their own practice. But I've seen it in the Netherlands. We had some private clinics, and there were some young guys. They started with the anterior approach, and their practice became fuller and fuller, and the other practice of the older surgeons, they became empty.
Start losing business. A successful business model like the posterior lateral approach, you don't want to change that because it takes 80 or 100 surgeries to get to this level. Like Joris said, that takes a long time. Not many people want to invest that.
But the residents I trained in The Hague, they are very familiar with that old, with the new method. It's their standard method nowadays. Now, and we introduced the fast track, so no drains, uncemented, 1 night in the hospital, and you can walk with 2 crutches for 2 weeks, and then with 1 crutch for another 2 weeks. You can drive your car after 3 weeks. You can do the swimming and playing golf or other sports after 6 weeks. So that's different from the old-fashioned method.
Excuse me,
Yeah.
there's someone who speaks
Oh, in España. Ja, ja, zo in Specialist daar de cadera, de vía anterior, el sin cortar músculos.
Igual en inglés entiendo, así que algunas cosas.
Oh, okay.
No pasa nada.
Oh, no pasa nada. Okay. Now, fast track was 1 night in the hospital. And this is my hobby in Spain. It was in Holland. Is to do second opinions for patients with problems after hip and knee replacements, suspicion of infection or fractures or other things. And I started in Holland with robotic surgery. With this surgery, you make a CT scan, a TAC, before, and do the operative planning. So in this patient, there was a hip replacement already on the other side, with some lengthening of the leg with 1.5 centimeter. So with the planning, we say, okay, we put a new hip in on this side, but we want to enlarge to make the other leg a little bit longer, to correct it. And with this CT, you have the planning, and then during the surgery, there's a camera, and you put some markers in the bone, and there's a robotic arm. In the arm, there's the saw, and then you can do your sawing, you can do your reaming of the acetabulum, and after putting in the trial components, you can see what's the effect. So you can see, okay, we put it in, it's only 2 millimeters difference between both legs, and the offset is normal, and so I did it more than 60 times in Holland, but in Spain it's not available. But I'm busy to get it introduced here in this area. Red flags in hip pain. If a patient has fever or loss of weight, or if there are more joints are involved, it can be another disease like rheuma. Swelling in the groin can be a tumor, or a pathologic fracture. That's a fracture without any trauma. So if you break your bone without a fracture, without a trauma, there must be something wrong. It can be a tumor or something else. Okay, short evaluation. If you have a tendinitis, a bursitis, or soft tissue problems, you can use infiltrations, but it's always better to start with physiotherapy. Start with physiotherapy for 6-8 weeks. If it doesn't help, do some further investigation. So make an X-ray or an MRI scan to see what's going on. The arthroscopy of the cam and the pincer impingement, or tears of your acetabulum. Don't do it above 45 years. It's better to do it to have it for the young patients. And with the osteoarthritis, if it's grade 1 or 2, so there's some cartilage left, start with physiotherapy, infiltrations like plasma or other things, or hyaluronic acid, but it will last only 1 year if you're happy. And if it's bone on bone, then it's better to do replacement surgery. So the take-home message is always start with a talk, anamnesis, medical history, physical examination, compare both sides, left and right. If there's no improvement of conservative treatment, do an X-ray in 2 directions. Exclude osteoarthritis first, and no infiltrations without a good diagnosis. I see many patients have had more than 10 infiltrations without a diagnosis. So I ask, what's the diagnosis? I don't know. That's not how I have been trained in the Netherlands. Thank you so much for the for coming. Are there any questions?
Can you say anything about how long the prosthesis is supposed to last?
Yeah, that's a good question. That's a good question.
Or then?
Now here's the prosthesis. I will show it to you. It's an uncemented prosthesis. It's the femoral component with some coating, and this coating ensures the ingrowth of the prosthesis in the bone. This is a ceramic head, and this is the acetabulum with coating and a polyethylene insert. Yeah, what can happen after the ingrowth is you can have some wear of the acetabulum, some of the polyethylene. And depends on your weight, depends on your activities, depends on a lot of things. And then you can replace only this insert, this inlay. So normally it lasts 20, 25 years. Normally.
And I understand that you also, you're not using cement for this kind of procedure.
It's not necessary.
Surgeons are still using cement, which makes...
Yeah, it's not necessary. Only if there's a very high degree of osteoporosis, there's no fixation, then you can use cement, but it's only for the stamp, for the cup.
Would that make an eventual operation in the future more difficult if you use cement?
No, it depends. You can do the revision in cement, so you can leave the well-fixed cement in the bone and then you put the new cement in and a shorter stem in it.
Okay.
So.
Joris,
how common is avascular necrosis?
Yeah, it depends on the use of medication. If you have had a lot of chemotherapy or prednisone or you're alcoholist.
What kind of other medications will harm the vasculature?
Yeah, it's the prednisone and the prednisone and chemotherapy.
And chemotherapy. Okay.
Yeah.
Oh.
Diving.
And sometimes diving, and sometimes you see that pregnancy.
Diving?
Oh.
Like scuba diving?
Scuba diving. Scuba diving.
I love the scuba diving.
Scuba diving, yeah.
If you do it according to the rules, there should be no problem with it. Too fast in a sense.
Oh yeah,
you get pressure sickness.
Yeah.
Yeah.
And that affects the hip.
Yes.
Yeah, the blood supply, there's only one blood vessel to the head of the hip.
Yeah.
So that's not too much.
Wow, cool.
Other questions? Más preguntas?
Doesn't seem to be the case, then...
One more.
One more.
What can you recommend to older people to prevent those common things that you do surgery on the hips? What's the best prevention, you think?
Now you must be lucky. Genetical lucky. Not be overweighted. Tough sporting. Like rugby, playing football, that can provoke some osteoarthritis.
Okay.
Contact sports.
Te lo hago en español.
¿Yo?
Yo soy fisioterapeuta y en realidad también viene porque yo trabajo con un doctor también traumatólogo, yo hago la rehabilitación posterior, pero en otra clínica de trabajo, que no hay traumatólogos, hay una paciente que tiene una osteoporosis severa. Entonces están dudando si a la paciente hacerle un tratamiento, un reemplazo o no, por el tema que el hueso no pueda soportar la prótesis.
Yeah.
Es una consulta que tengo.
Ja, es
pero
posible.
Osteoporosis severa,
Ja.
grado máximo.
Ja, pero osteoporosis no lo duele. Osteoporosis no lo duele, tiene más posibilidades de fracturas.
Claro,
pero
el problema es que le habían hecho en la otra cadera y cuando le pusieron la prótesis se rompió el hueso y entonces la prótesis es como entonces, ¿qué se le puede hacer a una paciente con...
Es mi hobby de reparar este paciente.
No, a ver, es una duda porque, claro, ¿qué se le puede hacer si no se le puede poner una prótesis? Es complicado.
Es complicado, pero hay soluciones de reparar esta situación.
Pero se le puede poner la prótesis, el hueso ese soporta.
Sí.
Vale. No, pregunta porque el otro hueso no lo soportó y la prótesis salió, el hueso se abrió y le tuvieron que hacer como...
Ja, como cerclaje.
Eso, un anclaje. Por eso es mi pregunta si en la otra pierna la puede llegar a soportar o le va a pasar lo mismo, no se sabe.
Ya, si hay un pierna roto, en otro lado, es mejor de usar cemento para el otro.
Cemento,
Ya.
claro. Vale.
Okay. Okay. Otra pregunta.
Other than being lucky and not playing contact sports,
Mhm.
I have heard several times that it's also very important to exercise, to
Mhm.
have our muscles strong, because as
Mhm.
we age,
Mhm.
our muscles are looser, they
Yeah.
lose up.
Mhm.
So if we practice a strength exercise, which is lifting weights,
Yeah, lifting weights.
Not-
Yeah, not too much, but
not too much,
you get the tendinitis or ruptures.
Not as a bodybuilder, but I mean, little by little start increasing our
Yeah.
muscle tone
Mhm.
in order to keep the structure tight.
Yes, that's
That's
I
also
agree.
a prevention type.
That's a prevention type, and train your reflexes.
Mm-hmm.
If you fall, you have some reflex. Then you fracture your wrist instead of your hip. Okay.
Any other questions from anybody about anything we can answer today? Otherwise, you will have to wait another 4 weeks for the next talk of one of our experts. We've had experts talking about wrist injuries already. We're gonna have some talk about spine surgery, robotic endoscopic spine surgery soon, and about shoulder surgery, I think.
Cartilage repair.
Cartilage repair in the knee, exactly, one of the newest things on the market as well, and seems to be doing a lot of harm to knee replacement surgeons, right? Which is
Mhm.
nice, which is good. And we're gonna add some other topics soon as well. Like Rick is probably going to talk about functional integrative medicine in the future, and I will probably add.
Just tell me when and I'll prepare.
I know.
SIBO.
Yeah, exactly. And I'm a gastroenterologist and an internal medicine specialist, and I will be talking about SIBO and the irritable bowel syndrome, which is a very common thing very soon. There's new research nowadays which can actually detect the cause of it, which is typically or many times a food intolerance or a parasite infection or a bacterial infection in your small intestine, which is not supposed to be. Once you can detect it, you can treat it, and the problem is gone. So there's news available, and I think we'll be continuing these nice talks here. And I think it's a very, very beautiful place here around the corner from our clinic. So many thanks to Banco Santander. Muchas gracias a vosotros. And to Joris, of course, for his availability all the time as one of our experts. And yes, I think we'll have some more words and the possibility to have a coffee downstairs as well and enjoy one of the famous coffees that Banco Santander is offering.
So yeah.
Yeah.
Thank you very much.